tips and tricks for fiber reinforced direct composites. Don't forget to follow Romero Dental Seminars in all our social media platforms like Instagram and Facebook. We want to thank our sponsors for making this webinar possible and allowing us to provide one free CE credit. Thanks to Colteen, Oral Arts, Dent Logics, and Romero Dental Seminars. In order for us to provide you with the 1 CE credit, please visit www.romerodentalseminars.com. Click on the webinar links, and in the drop-down menu, click on CE Quizzes. You will find the CE quiz in that page. Make sure that you download it, answer the questions, scan it, and email it to us to romerodentalseminars@gmail.com. And also, please don't forget to visit our YouTube channel, Romero Dental Seminars, and subscribe to our channel so that you can get automated emails every time we upload new content. Our learning objectives for today: we're first going to help you identify the different types of fibers available in the market. Understand the steps required during the preparation of the dental substrate, and learn how to obtain a natural looking and highly polished restoration. So let's get to it. Tip and trick number 1, selection of the fiber. The first thing you need to know is that there are two different types of fibers available in the market. One of them is called the glass fiber, and the other one the polyethylene fibers. Now these fibers are different, and this is what you have to understand. Which one would you select clinically? I have actually used both fibers, the glass fibers and the polyethylene fibers. But the ones that I use on a daily basis are the polyethylene fibers, and in a minute I'll tell you why. The glass fibers are excellent fibers. They're strong, they're like fiberglass, same material that they use to make some cars and make some airplanes or parts of airplanes. But the downside to the glass fibers is that the glass fiber comes already embedded in resin, which means that when you light cure, if you're trying to light cure a portion of the fiber, you will most likely affect the entire fiber. So let's look at the case on the left-hand side of my screen. You can see that that is one that I'm restoring with the glass fiber. You can tell that the glass fiber is already surrounded. The fibers are surrounded by like a matrix material, like a glassy matrix material, that you see it bonded to tooth number 7 and 9. And the thing that I want you to see is that this fiber, because it's already embedded or already filled with this resin material, it's thicker than a polyethylene fiber. A polyethylene fiber that is also already impregnated with resin and some silane in order for you to be able to bond to, it's still a flexible fiber. You still have to add the resin component to that fiber in order for it to set, to polymerize, and to be stiff. In this glass fiber, even though initially the glass fiber is a little bit flexible, just a little bit flexible, again, when you hit it with the light, you will have the entire fiber polymerizing. And because it's already surrounded by this matrix, it is thicker. I would say 1 to 2 millimeters thick, which in certain cases, if you're going to do a surface retained fiber reinforced composite tooth like the one that we're doing here, this 3-unit or type of Maryland composite bridge, if you don't have a lot of or enough interocclusal space, the thickness of this fiber will compromise your case. You will have to actually reduce tooth structure in order for you to be able to bond the fiber within the tooth and not surface retained like the one that I'm trying to do here. In this particular case, we did have enough occlusal clearance from the patient, so we were able to use this glass fiber. But that is one of the downsides of the glass fiber. Not only that, it makes it a little bit more difficult to handle because, again, it may light cure, it will light cure. You have to be very careful in the areas where you want to light cure, because don't forget, you have to adapt this fiber to the contours of the tooth that you're missing and to the contours of the natural tooth that you're using as abutment teeth. So that is the tricky part with the glass fibers, and that's the reason why I don't recommend them I don't recommend them for daily use. I think that they're great fibers for splinting teeth in periodontal patients, maybe even for orthodontic patients. If you're going to put them on the lingual side, they can still be surface retained. But again, the idea is that these fibers are not exposed to the oral environment. You want to make sure that they're always covered by resin, and the thicker they are, the more resin you're going to have to, or the thicker the layer of resin is going to appear on the natural tooth structure, and also may interfere with the occlusion of the patient. On the other hand, on the right hand side, you're seeing the polyethylene fibers, and those are the ones that I'm going to really go into them, because those are the ones that I use daily, and those are the ones that I really recommend. Because again, even though they're silinated, they're pre-treated before you get them, they're still extremely flexible. They actually appear to be like a cloth. So you actually have to add the resin to them, and by adding that resin, you're going to be able to polymerize them and make them stiff or rigid. So if you are going to connect to one tooth, let's say that you're using the polyethylene fiber on the same case that I'm showing you on the left hand side, you may be able to apply just a little bit of the resin on one connector, light cure directly, and the rest of your fiber is still going to be uncured. So it's still going to be flexible enough for you to shape obtain the right form or shape of the fiber around these natural teeth and on the abutment area. So again, from a clinical standpoint, for direct composite restorations, I would highly recommend that you choose a polyethylene fiber compared to the glass fiber. Not that, and my only preference has to do with the clinical aspect of them, meaning the thickness of the fiber and the handling of the fiber, which is a lot easier and thinner if you choose the polyethylene fiber. So these are two good examples. On the left hand side, you see the Grand Tech from Voco. That is a glass fiber. You can see that they come in individual packages. You open these packages, they are obviously protected from light so that they don't polymerize while they're packaged. They're protected from oxygen. They're vacuum sealed. You get these packages, you open one of these packages, and you're ready to cut the fiber at the length that you want to use depending on the case, and you go from there. On the other hand, the polyethylene fibers, which this is another benefit of the polyethylene fibers, because they are not filled with resin. They are salinated. They are ready to receive the resin, but they're still very flexible. These fibers don't have shelf life. They don't expire. So you can have, and again, they will last you a long time, because you can see the kit comes with 3 different rolls. The beauty of these rolls is that each fiber on that roll has a different thickness. So you will see that, width. So you will see that you have either 1.5, 2 millimeters, or 3 millimeter width of the fiber, which will really depend on the space, interocclusal space that you have for your patient or the tooth that you're trying to restore. Normally, I recommend using these techniques for anterior teeth. Maybe go all the way down to premolar areas. I have restored some premolars with these fibers. If you're going to do individual teeth, you may go all the way back to the molars. But if you're going to do like a 3-unit or a Maryland type of bridge, well, I only recommend those for anterior teeth and for premolars, all the way back to the premolars. Mainly the number one reason why I'm using them is not to do any Maryland bridges, but only restore severely broken down teeth. So I actually use these fibers to restore teeth that otherwise would be most likely extracted by other clinicians. And I don't have anything against extractions. I don't have anything against implants. I'm going to tell you when I share with you my clinical cases, when is it that I determine, either keeping the tooth or maybe extracting the tooth and going forward with another treatment option. But again, you can see the Construct kit from Kerr. Very nice with the scissors to section the fibers. You have these pencils to mark the length of the fibers. You have the tweezers to kind of hold the fibers instead of holding it with your hands. And you have 3 large flowable resin syringes, which you're going to use in order for you to wet this fiber before bonding it to the tooth. You can use that, and once those expires, because those do have shelf life, you can always just use their regular Herculite Flow is what I use every day, or any other flowable composite that you're using in your office to wet your fibers. So again, you can buy the intro kit, or you can buy just the fibers, whichever suits your needs in your office. This is again the example of the glass fiber. You can see that they come individually packaged. You can see that fiber right there, that yellow strip that you see on the back. they're pretty long, and that's another downside to them. You know, they're pre-sized. If you're gonna use just half of it, you have to get them out of this vacuum sealed package. If the light hits them, they're gonna set on you. So you know, that's another benefit of having these little rolls, that you literally are gonna cut exactly what you need, so you don't have to waste your materials, right? So that's another downside to these glass fibers. But again, if you're gonna splint ortho teeth or periodontally involved teeth, well, maybe you do need a lengthy strip of this glass fiber. But you can also see the thickness of the fiber, because the fibers are actually within that glassy matrix, that resin matrix that you see there. So, you know, they already come completely covered by this resin matrix that you're going to add more composite to. So you're going to just make it thicker. And again, when you're light curing it, the whole fiber will be affected by the light. So you got to be very particular in the way that you light cure. I actually, when I'm using glass fibers, you know, I only tack cure them on one little side, trying to prevent the light from hitting the rest of the fiber. If I have to shape this fiber in any specific form in order for me to be able to restore a missing tooth. I would not recommend using this fiber if you're going to go intracanal, because this fiber is very, very difficult to, you know, it's almost impossible because of the thickness of the fiber to put it within the canals. And I'll share with you some cases so that you will understand better what I'm trying to say about, you know, by being very difficult to use this fiber to bond intracanal. And you'll see it for yourself. But the most important thing, again, is that the thickness of this fiber will most likely interfere with the occlusion of your patient. And that's one of the reasons why I prefer using the polyethylene fibers. But again, I have used glass fibers. They still have, you know, they still have a good place, I would say, in restorative dentistry. And if you have the cases, why not? And this is one of the cases that I was restoring. This patient, as you can see, has a kind of like an acrylic removable partial denture on the mandibular arch. You know, patient, very low income patient. He had lost tooth number 8 due to an trauma. So we had extracted that tooth. We waited a couple of weeks. You can see that there's some healing already going on the side of tooth number 8. And what we really wanted to is to try to maintain that the shape of the tissue there, that pontic, or the ovoid pontic shape of the in the side of tooth number 8. And the other thing that we had is that because we had this removable partial denture made out of acrylic, it was very easy for me to just go ahead and adjust a little bit that partial, give this patient that thick glass fiber, which is obviously gonna, you know, because it's thick and it was already it already had that resin matrix surrounding the glass fibers. You know, I was able to bond it to the neighboring teeth, incorporate this fiber, surface retain on the lingual aspect of the teeth, and then add an additional fiber right on the buccal, just in between both 7 and 9. So this is like a sandwich technique, you know, one fiber on the lingual and another very small piece of fiber right on top of that fiber on the lingual. And then I wrapped it around with this little button made out of composite. So you can see I also restored the, you know, class 5s both on 7 and 9. I bonded that fiber on the lingual. I created a little bit of, you know, improved the contours of because the space was going to be too wide, so I had to improve the contours of 7 and 10, 7 mesial and 10, both mesial surfaces of 7 and 9, I'm sorry. So you can see that part of the fiber was already covered by those layers of composite that I've added there. Now I've created the correct mesial distal space for me to build that single tooth that the patient was missing. And we always start with that little button. That little button surrounds the fiber 360 degrees, you know, lingually and buccally. Don't forget, these fibers cannot be exposed to the oral environment. You want to make sure that they're completely covered by your restorative material. So once we have that button, we go ahead and we start applying in different layers. We start applying the composite initially towards the cervical aspect of the tooth, because we want to make, you know, we want to try to maintain that ovoid pontic towards the tissue, towards the area where we extracted the tooth. And then what we do is that we start lengthening it, we start laying our composite more towards the incisal. On the right hand side, you can see the completed case. This is immediately after I polished the restoration on tooth number 8. You can see that the fiber is completely covered by resin composite. We have allowed some space in the embrasure areas, gingival embrasure areas, for cleanliness of the prosthesis. And again, this is a very, immediate, this is chair side, is done the same day. So the patient leaves my practice with the tooth. And what we tell our patients when we're doing these type of restorations is that this is what we call a long-term temporary restoration. This is better than giving the patient a flipper. This is better than just bonding a tooth to the neighboring teeth, because we all know that those connectors most likely will break if they're bonded with only composite. This is a glass fiber. This is a very strong structure that is underneath this composite tooth, and that is going to not only bond to the neighboring teeth, but it's going to give that added strength that we need so that the patient can function with this tooth. Obviously, there was some adjustment in the occlusion. As I said before, we had to remove a little bit of the acrylic on the removable partial denture that the patient had on the lower arch. We adjusted a little bit the teeth. We adjusted a little bit his natural teeth, but we were able to to have these connectors on 7 and 9 that were completely covered by composite on the lingual side. And they were only surface retained. And why am I saying that? Because if this patient ever transitions to an implant on that site, and and we restore that site, most likely, for sure, we're going to be able to remove this fiber, which was only surface retained, polish the lingual surfaces of 7 and 9, and we're done. There are no preparations. There are no class 3s that we need to restore afterwards. This is only surface retained, very, very conservative restoration. And when you look at the longevity of these bridges, this is a photo that I obtained from this patient 3 years after I had delivered this glass fiber reinforced composite tooth. Now you can see that the patient wasn't too careful with his teeth, and you can see the chipping of the incisal edge. This is the natural incisal edge of tooth number 7. So the patient didn't have the perfect occlusion, he didn't have the perfect hygiene, but other than that, the bridge is still there and it's still holding on strong. So I don't see, even though I do call them transitional long-term transitional restorations, and I let the patients know that I don't give them a time, I don't give them any any guarantee that this is going to be there for 3 or 5 years. I do tell the patients this is better than having a flipper. This is better than just sticking a tooth to your neighboring teeth. This is a much elaborate prosthesis that will give you the time that you may need, maybe a year, maybe 2 years, maybe 6 months, whatever time the patient needs to transition to the final or a better restorative option, which in this particular case would have been an implant. But we also have to realize that many times our patients financially can't just move forward easily to the next option. So this is a good transitional option that I know today, because I've witnessed it throughout my 27 years of practice, that these bridges can last a long time. Worst case scenario, if they ever fracture, they're easy to repair. You can always add fibers to them. And worst case, even if they are a fatal fracture and you have to remove the whole prosthesis, you can always redo this type of prosthesis and give the patient 3 more years with a new fiber reinforced prosthesis. So keep that in mind. There's many studies out there that have viewed these type of prosthesis, and not only that they're very satisfying for the patient, but from a clinical standpoint, they behave very well when elaborated properly. And that's why I'm trying to get into all the little things about these fibers. We just saw a clinical example of the use of a glass fiber, and you can see that these glass fibers behave very, very well. You already know the good things about the glass fibers, and the small downside that they do have, being the thickness and the option, the polymerization issue that you may have. But let me talk to you about the polyethylene fibers, which is the second option that we have, and which for me today is the only option. This is the only fiber that I'm using today. I've used other fibers before, but today I'm only using the polyethylene fibers, and for the reasons that I've already said. Now, this is the one that I use in my office. It's called Construct. It's made by Kerr, and the one that I use the most is actually the 1 millimeter width fiber, and that's the one that you're seeing here. Is that little green wheel that you see on the left hand side. You can see the resin that comes with it. It's a very nice, flowable, creamy resin, and it has just natural shade is what they call it. It's a very universal tooth colored resin that you can wet this fiber with. And there are the pliers that you use to cut these fibers. These are special pliers that you use, so that you can see on the right hand side, you can see one of the fibers that I have sectioned in my office, and it's a perfect sectioning of the fiber that you obtain with these special pliers that actually come in that introductory kit that you would need to have in your office in order for you to be able to do these restorations. So the other thing that I want you to tell you is that, these fibers, these polyethylene fibers, I'm showing you here a graph of a microphotography of a polyethylene fiber. That would be photo A. But I want you to compare it to the B, C, and D photos, which are all glass fibers. And you can see that the woven type of fibers, which is the polyethylene fiber, the reason why many studies have shown that these are really, really strong fibers is because you can see the way that they're knitted, the way that they're elaborated. You can see that the direction of the fibers is going everywhere. It's going up, down, left, right. So you have this combination. That's why they call them woven fibers. This combination of multi-directional fibers that are going everywhere that actually give this fiber, this specific fiber, its strength. When you compare it to the glass fibers, you can see that glass fibers can be either braided, unidirectional fibers. So the way that the glass fibers come together is a little bit different than the way that the polyethylene fibers are actually manufactured. Now, from a clinical standpoint, honestly, I have used both fibers and they both behave fairly well. Today, I'm using the polyethylene fiber because from a clinical standpoint, in my hands, they are easier to use. Even though there is some research out there that have demonstrated that the polyethylene fibers are more resistant from a clinical standpoint, I have experienced in my practice both fibers to behave clinically in an acceptable way. But definitely it's easier to use, in my mind at least, and in my hands, the polyethylene fibers, because of the fact that you are able to wet them as much as you want, and you can wet one portion and leave the other portion unwet so that you only cure one side before curing the other side. So you can adapt these fibers better to the actual contours of teeth, and that is the reason why I think, at least today, that's the reason why I'm using them more or solely in my practice, because of that particular fact. But one of the things from a clinical, from a research standpoint, that gives these fibers the benefit of the or the improved strength is actually the way that these fibers are knitted, or are, that's why they call them woven fibers. They go in multi-directional fibers so that they add that, they give you that added strength that you need for your restorations. So just to give you a clinical example, I'm going to share one clinical case that we did in when I was a program director at the Dental College of Georgia with Dr. Cassandra Mitchell. I do want to give her credit for this case. She had this patient that had this tooth number 10, and these are cases that we see every single day. This patient had that tooth treatment plan for extraction, implant, and a crown. And 10 years went by and the patient still had the tooth fractured and the tooth was not extracted and no implant was placed. And the only reason why that happened was because the patient financially was never ready for that next step. So he was literally walking around the street with an endo-treated tooth with no periapical lesion. That endo treatment was sealed, so there was no contamination of the endo, but the tooth was fractured. And he did not get it restored because the plan was to extract the tooth. Well, after 10 years, and then we're looking at this x-ray with Dr. Mitchell, and we're like, you know what? This tooth looks great. I mean, I think that we can go ahead and add a fiber. We know that we have today the techniques, we have the materials in order for us to restore this tooth, so why not? So Dr. Mitchell went ahead, treatment planned this case. She elaborated a wax up. She took an impression, elaborated a wax up. And the first thing that I always recommend is that you have to have ideal control of the operative field in order for you to be able to restore these cases without any issues. And as you're seeing on the right hand side, she was able to obtain really, really good isolation of the tooth using what we call or using a B4 clamp made by Colteen. This B4 clamp is part of the Brinker kit clamps. And it's a very, very useful clamp. This one and the modified 212 clamp are my go-to clamps when it comes down to severely broken down teeth, because they're easy to apply, they're easy to sit around the tooth, and they create good retraction of the rubber dam, which means they push the rubber dam more apically to make sure that it goes subgingivally, as you are seeing here on the right hand side. So once she was able to accomplish that beautiful isolation, she went ahead, she prepared the substrate, she bonded the fiber. That's what you're seeing there, and I'm going to walk you through step by step on how we do this technique. But for now, I just want to show you this example of the polyethylene fiber. So she went ahead, she cut the fiber at the length that she needed, she wetted the fiber, and she bonded the fiber to 2 to 3 millimeters within that canal. So she removed some of the composite that was in the axis of the canal, and she was able to bond the fiber 2 to 3 millimeters within the canal. You can see that she was able to build that tooth up from the lingual to the facial using her wax up as a guide. So she fabricated a matrix out of the impression that she obtained. You can also do this free-handed if you have the skills to build teeth without a matrix guide. But a matrix guide would be the way to go. It's easier and it's very predictable. And you can see her final result on the right-hand side. Highly polished restoration. You can see that the tooth is literally 95% of this tooth structure today is made out of composite with that fiber embedded within that composite. So that fiber, again, you don't see any of the fiber exposed. If you look at the lingual aspect, this is the 30-day post-op photo of the patient. You can see that the tooth is still there. His occlusion is not the best occlusion in the world. He's an edge-to-edge type of occlusion. So we had very light occlusion on that tooth. But regardless of that, the tooth is still there. Now, and me and you know that eventually the tooth is going to be in contact. It's going to probably move a little bit and it's going to touch some of the tooth of the opposing teeth. So we're not afraid of having teeth in occlusion. We just want to make sure that the patient understands that this is a 95% tooth that we built for him. But we are also confident that the polyethylene fiber is going to do its part. And I'll show you cases with longer follow-up photos. But again, in this particular case, we had a 30-day follow-up photo. You can see on the lingual side of the restoration, this is 30 days later. You don't see any of the fiber exposed. And that is critical. It is critical for you to have a wax up because you want to make sure that your fiber is centered buccal lingually. You want to make sure that you're going to have enough composite on the buccal as well as on the lingual so that this fiber is 100% covered by composite. If the fiber is not covered by composite, what you're going to have or what you're going to see clinically in 30 or 60 days, you will see bacterial growth on that fiber because obviously the fiber has thousands and thousands of little irregularities where plaque are going to accumulate. They're going to attach to it and accumulate, and that will with time will affect the fiber in a way that you will lose, you will start affecting your composite. You will, it will just degrade from there on. So make sure that you always have the fiber well located and the fiber is 100% covered by tooth structure. So let's go to our tip and trick number 2, which is the preparation of our substrate. Now, I'm going to now walk you through step by step on how you manage a tooth to be able to do these restorations. Now, in this particular case, you can see I'm sharing with you cases that are, that many of us would say, let's go ahead and extract that tooth. Let's not give that tooth another chance. But the way that I see it is a little bit different because I do extract teeth and I do place implants. But, the one thing that we all want when we want to go that route is that we want to have bone. And in this particular case, this tooth number 10 that was fractured had a root canal with no periapical lesion. So the bone was intact around the root and the patient financially did not have the means to go that route at this moment. She had other issues. She had caries. She had another teeth that needed attention. So we wanted to concentrate on let's get this mouth healthier. And that is not extracting this root and placing an implant. I needed to control caries. There was a lot of other things, modified diet. There was a lot of other things that I needed to do for this patient. And she understood, there was other important things that would need also for her to be prepared financially to go forward with the other treatments that she needed. So what we decided is, okay, the tooth fracture, it has a root canal. The root canal is doing well. There's no contamination. There's no periapical lesion. Let's go ahead and let's fiber reinforce this root. And that is what we're doing, very frequently today because we want to preserve bone. We're calling these long-term transitional restorations so that we preserve bone around this root. And whenever the patient is ready for me to extract that tooth, I may be able even to place an immediate implant with very little to no bone graft around that implant because of the size of the root. So keep that in mind because again, if you extract that root and you place a graft, you still only have maybe 4 to 6 months to go ahead and move forward with your implant placement. And if the patient is not ready financially, most likely you're gonna, you just spend a lot of material, time, and money of the patient to get that graft, but you can move forward with the final implant and prosthesis. So that's the reason why we like saving these teeth, and we have the materials and the techniques to do so today. On the right hand side, now you're seeing the second clamp that I was talking about, the modified 212 clamp. That modified 212 clamp is giving me the opportunity to retract the rubber dam around that little root. You can see that I've been able to submerge or invert my rubber dam subgingivally all around that tooth. No tissue exposed, no bleeding, nothing. Everything is underneath the rubber dam, so I have full control of the operative field. If you want to know how I'm able to isolate many of these teeth, please do not forget to visit my YouTube channel, Romero Dental Seminars, and watch our tips and tricks of basic rubber dam isolation. And there's a second video called Tips and Tricks on Advanced Rubber Dam Isolation, where we actually teach you on a clinical video step by step how you need or what you need to do to modify these clamps. So please make sure that you visit our YouTube channel, subscribe to the channel, but most importantly, watch these two videos. These two videos are really going to give you everything you need to know in order for you to accomplish ideal isolation on every one of your cases. So again, we're placing that 212 clamp. Our step number 2 is going to be to remove 2 to 3 millimeters of the gutta percha within the canal. We got to create space for that fiber. We don't need a post. We don't need to go 10 or 8 millimeters within the canal. We just need the fiber, and we need that fiber to be bonded 2 to 3 millimeters within the canal. And that's another beauty of this technique. If you were to place a post on a tooth like this that has very little to no ferrule, that post is going to increase the risk of fracture of the root. And my ultimate goal is to keep the root in the patient's mouth. We want to keep this root as long as we can, so that when we transition to our final prosthesis, which is an implant and a crown, we have bone. That's what I want to try to accomplish. So I'm not going to place a post in this canal. I'm going to place a fiber. And I only need 2 to 3 millimeters of that canal in that axis in order for me to bond that fiber. That's all I need, because the fiber, all it needs to do is hold that crown in place. And I've been able to accomplish that in the technique actually that has been developed for this type of procedures. Mandates that you go 2 to 3 millimeters within the canal. So I go ahead and I use a very fine diamond. I go ahead and I remove the 2 to 3 millimeters of gutta percha within the canal. You are seeing my step number 3 is to use a periodontal probe and measure the canal. Make sure that I am 2 to 3 millimeters within the canal. Step number 4, I'm going to go ahead and use aluminum oxide. 30 to 50 microns is what I recommend, with an intraoral micro etcher. And I go ahead and I sandblast the remaining tooth structure. What this is going to do for me is that it's going to improve bonding on this tertiary dentin that is all over the place, because we know that this is not the best dentin to bond to. So there are some studies out there that have shown that by micro etching this dentin, you're going to get a better quality of substrate. You're going to improve bonding, but also I'm cleaning the substrate. I'm cleaning whatever debris is left in the canal. I'm cleaning whatever debris is left around the enamel, around that dentin. So I'm making sure that I have a nice and clean with multiple porosities, because that's another benefit of the micro etching. You're creating a very irregular surface, and that's what you need, because you want to make sure that your resin, after you acid etch and you clean the substrate and you etch the enamel, you get that hybrid layer with a lot of irregularities around there, so that there's that micro mechanical retention that we all want to accomplish after micro etching and phosphoric acid etching of the substrate. So you can see step number 4, step number 5, we rinse, we bone dry that area. You can see how nice and clean the substrate is. And now, once everything is nice and dry, we're going to go ahead and we're going to try that fiber. We're going to make sure that the fiber goes in 2 to 3 millimeters within the canal. That's why I'm using the 1 millimeter with fiber mainly for these type of cases, because again, you don't have huge canals. So we're going to place that fiber in the canal, and we want to make sure that we have enough fiber so that we can build the tooth around it. But at the same time, we want to make sure that the fiber is short enough on the incisal portion so that we don't have any fiber exposed once we're done with the tooth. So there's a couple of things that you got to make sure that you're measuring. And that's why I like having a wax up. That's why I like fabricating a matrix, because a matrix is going to give me an idea of what I'm going to end up having, where the incisal edge is going to be located, where the lingual surface is going to be located, and approximately an idea of where the buccal surface is going to end up being once I cover the whole tooth with fiber. So right now, with composite. So right now we try in the fiber, and we're going to go ahead and do our step number 7, which is now acid etch, or using phosphoric acid, 35 to 40% acid etching of that substrate for 15 to 20 seconds we go ahead and we rinse and we dry. And when we rinse, you can see that I'm rinsing the canal. I'm flushing the canal with a very fine needle. I'm flushing the canal using water so that I'm sure that I'm getting all that acidity out of the canal. It is critical for you to do that, because if the environment within those 2 to 3 millimeters is very acidic, you're going to have an issue with polymerization of your resin. So make sure that you rinse that canal very well. You bone dry, and you dry, but you allow that dentin to be a little bit wet. You can see that I'm drying the canal with a paper point on my step number 9. And once you do that, you're ready for your 2-step bonding system, and that's what I'm using in these cases. I like using a 2-step because I like having control over the primer to eliminate the solvent, and then I like to have control over my adhesive. So I'm going to use, for this particular case, I'm using OptiBond FL, but there's other options out there in the market. I like using OptiBond Extra Universal as well, but this in particular was with OptiBond FL, which in my mind is the gold standard for these type of procedures in restorative dentistry. So you saw step number 1 as step number 10. Step number 11 is now the adhesive. So the second bottle of OptiBond FL, I'm going to make sure that I apply that adhesive all around the dentin, all around the enamel, and within the canal. You want to make sure that you have very thin micro brushes, and they make them in different sizes so that you can wet the walls of the canal very nicely, and you can get your adhesive in there, because you're going to have to bond to those walls. The other thing that I want you to know is that once you light cure, you as you can see on step number 12, you're going to inject a little bit of flowable composite within the canal at the same time that you're wetting the fiber with flowable composite, so that when you place a fiber within the canal, you don't have any voids within the canal. And ask me how I know that. I've made that mistake, and you got to make sure that that you don't make that mistake. So just go ahead and apply a little bit of flowable composite within the canal. Then you apply the flowable composite on the fiber, and then you sit that fiber within the canal, and that's how you prevent having any voids within that little 2 to 3 millimeter canal access that you just created. And just to make sure that you understand, you can see that on the left hand side I have a photo of the fiber that I sectioned, the one that I was going to use for this case. As you can see, that fiber has silane, so it's ready to receive the flowable composite, but it's not wet with flowable composite. That's how you cut it out of the little wheel where the fiber comes rolled up. In the middle photo, I'm actually applying some of that flowable composite that comes with the kit, and I literally just put it on a little well or a dappen dish, anything like that. You just put a little bit of that of the flowable composite, and then you can see that I'm literally embedding the fiber within the composite, making sure that the entire fiber is wet, is filled with this resin, this flowable composite, as you can see on the right hand side. And once it's all filled, I'm ready to go in, and you can see that I'm now applying the fiber. I push the fiber within the 2 to 3 millimeters within the canal. Make sure that you have flowable composite already in the canal. You add the flowable composite to the fiber, as I said before, and now you seat it within the canal. You can see that I have my matrix band on the lingual aspect, my matrix, my putty matrix, that is guiding I know exactly where that lingual surface is going to be, and I'm trying to place that fiber right in the center, right in between the lingual and where my future buccal contours are going to be. Because again, I want this fiber to be fully surrounded by resin composite. Once you selected the final position, you go ahead and light cure, and what you see on step number 15 is now the cured polyethylene fiber. So now this fiber is stiff, very, very stiff. It's like a post. And now you're going to start building around that fiber your restoration. So that's what takes me to my tip and trick number 3, which is what are the layers how do I recommend you layering your resin composites? So you know that you have the fiber. We're going to follow the same case. So you have the fiber, and my first layer is always going to be the lingual layer. That lingual layer I'm going to apply directly on top of my putty matrix, and then I'm going to sit the matrix directly onto the patient's mouth. You got to make sure that this matrix is fully seated, and you can see that it's fully seated on the canine and the central incisor. Then and you apply a little bit of flowable composite on the lingual aspect of the fiber, so that when you sit this microhybrid composite that is on your matrix, you seat it on the patient's mouth, that flowable composite interacts with that layer, and you don't get any voids in between them. Now I'm using, for this particular case, I'm using Brilliant Everglow A2B2, which is a dual shade system made by Colteen. Brilliant Everglow, it's a beautiful type of restorative material. I like it because the opacity of the composite is the ideal opacity. You have, two shades. It's a dual shade system that you can match either A2 or B2 based on your patient's needs, and it's very easy to manipulate. And most importantly, you'll see the natural appearance that you achieve with this type of restorative, with this particular composite. Very simplified system to use, but you have the right opacity so that you don't have to. I'm going to use only A2, B2, and I'll show you exactly how I do this, just so that you know how we accomplish the end result that you're going to see for this particular case. So once we bond that fiber to the lingual layer, we light cure it, and we remove the lingual matrix, as you can see on the right hand side of the photo of the screen. And now, if you have any voids between the fiber and the lingual layer, you go ahead and you're going to fill them up with flowable composite. And just a little bit if you need. I had a little bit of, you can see the little voids that I had here on the distal and the mesial of the fiber, right on the cervical aspect. And I went ahead and I just injected a little bit of flowable composite on both sides. I make sure that I push it in with a very thin instrument, and I light cure directly. So that's, you got to make sure that you do that before you start layering the you start with the next layers, so that you don't end up having any voids anywhere. So you can see I've covered all the voids on the mesial and the lingual. I'm now placing my mylar strip, and what I'm going to do now is I'm going to create my proximal contacts on the lingual side of my restoration. So I'm still working on the lingual wall. You can see that on the left-hand side photo, I don't have contacts between the on the mesial and the distal. I still have a little bit of separation, and I got to make sure that I have contacts. I want to accomplish that because the only way I'm going to be able to then follow up with the following layers, my mesial mylar pool and distal mylar pool, I got to make sure that I have a really nice and tight contact interproximally. So I want to accomplish that on that lingual layer. And that's what you're seeing that I'm doing. I apply a little bit of composite. And the reason why you see this composite very nice and soft or kind of like more of a flowable consistency is because I warm my composite up in a composite warmer. I put my composite up, I warm it, for 20 to 30 seconds. It changes the properties of the composite, meaning that the way that you can manipulate the composite, not the properties, but the manipulation aspect of the composite. It's modified. It makes it a little more flowable, if you want to call it that way. A lot easier for you to manipulate intraorally, or at least in my hands, it works better. And you can see that I'm using a very thin composite instrument, just pushing that composite against the neighboring tooth, only having the mylar strip, no wedges, making sure that I'm recreating the emergence profile. You can see up here, I've pushed the mylar to go underneath or subgingival so that I can adapt the composite very well and create a very nice mesial. And then I'm going to do the same on the distal, and I'm going to create a very nice mesial and distal gingival embrasures. Using a brush, I'm just going to smooth that composite all the way down to the incisal edge. And again, I do that the same thing. I do it on the distal. And now you can see that I have a contact. You can see that I have a contact on the mesial, and you can see that I have a contact on the distal. And you can see it from the lingual, from the incisal view, I have a contact. So now I know that I'm going to be able to hold my mylar in place and just push my mylar when I want to recreate my line angles. But first, I'm going to go obviously and create my opacity. So how do I do that? Coltine has another composite called Miris 2. And Miris 2 is a wonderful, highly aesthetic composite material that comes in multiple shades. And that kit also has these flowable composites that are tints that are helpful to modify any type of color. Within those tints, and there's 4 that come in the kit, there's one called the white opaque tint. And that white opaque tint that is in that Miris 2 kit that you can buy separately, I like to apply it on that lingual layer because, again, I'm going to build this tooth up completely using a single shade. So I want to make sure that I accomplish that ideal opacity. I don't want my restoration to be translucent at all. So I'm going to paint a very thin layer of this white opaque right on that lingual layer that I just created so that I get the right opacity once I'm done with my restoration. If you were to skip this case using any universal composite out there, you're going to most likely get a more translucent tooth than the neighboring teeth. So keep that in mind. This is a critical step. Once you do that, now I'm going to go ahead using exactly the same shade, the A2, B2. I'm going to go ahead and build the lingual layer, which is going to, the gingival layer, which is going to give me my emergence profile. And again, you can see me using that brush to make it nice and smooth and give it the shape that I need to give it. Now I've accomplished my gingival height of contour. This is going to be followed by my line angles with the mesial malar pool, the distal malar pool, and you can see on the right hand side I've created the mesial line angle and the distal line angle, to then go to my final facial increment. And you can see that all these increments are light cured individually. You can see now I've applied the composite on the middle of the facial aspect between both my mesial and distal line angles, and I'm going to now apply that composite, smooth it out, use my brush, make it blend in, and then I light cure, and that's what you see on the right hand side. So now I'm ready for the finishing process. And if you look at this from the beginning to the end of the actual layering, you already have a tooth. So all you have to do now is use your different disc and burrs to make this tooth fit in that mouth the way it should. So you're going to now, I'm going to share with you my tip and trick number 4, which is finishing and polishing. And again, finishing and polishing, I'm going to use a combination of disc and fine diamond burrs. The disc system that I like using the most is the Softless system from 3M. And you can see here that I am using the coarse disc, and that's the first one that I use just to remove, to give that tooth the right length and the right mesial and distal incisal embrasure shapes. And then I'm going to use the 8888 diamond burr from Comet, and this burr, it's a medium grit diamond which has a red stripe, and it's a beautiful burr. I have it in every single one of my operative kits. I use it a lot because this is the burr that I use to just get that natural contours on the facial aspect of this particular tooth, or any tooth that I'm restoring, even with when I do composite veneers. I'm going to do my developmental grooves. I'm going to remove any over contours that I have. It's a nice burr to get all the way up to the gingival aspect. So I use just the 8888 to finalize my contours on the facial aspect. Then you're going to see that I'm going to go ahead and use these fine finishing strips. These are made by GC America. They're called Epitex, and they're very, very nice and fine. They have diamond impregnated. They're diamond impregnated, so you can go in and just polish without running the risk of removing your contact. And you can see that you need to use it in 2 different ways. In your gingival embrasure areas, you want to use it as a C shape, and your interproximal contact areas, you want to use it with an S shape, as you're seeing on the photo. This is how you assure yourself that you're not going to remove any of the contacts. These finishing strips are very, very thin, so it's very hard for you to actually remove your the interproximal contact that you achieve. So you got to be careful, but it's not that easy to do it with this particular finishing strip. Any excess that you have on the gingival embrasure area, you can always use this surgical blade, the 12 blade that you're seeing right there on the screen, and just go ahead and clean that area. Then I'm going to go ahead and jump to my second disc, which is the orange disc on the Softless system kit. You have the red being the coarse, the orange being the medium grit disc, and that's the one that you're going to use just to refine any aspects of your facial contours. On the lingual side, I'm going to use a football shaped carbide, and I'm going to use an enhanced point to polish. Once you've gone through that disc, and you can see that I'm going to the third disc, which is the dark orange, I would say the light orange type of disc, and this is now the medium fine disc. You're going to go ahead again, just light touches here and there. This is not going to remove a lot. It's going to actually start giving you more of a polished surface. Now I'm going to go ahead and, with my enhanced point, I'm going to go into any developmental grooves that I've created. I don't go all the way down to the yellow disc, which is the fine disc in the Softless system. I only use either the first or the second. I would say 90% of the times, and maybe 5 or 7% of the times I go to the third disc. But normally I use the first, the red, the coarse, and the medium disc. Those are the ones that I use every single time. And then I jump to my burrs and to my enhanced points. And finally, to get my high glossy facial surface, I'm going to use these wheels that are called Shape Guard, and they're made by Colteen. I have used multiple systems with these wheels. Many companies make them, but I have yet to find one that gives me a more polished, highly polished gloss surface with keeping or retaining my texture that I've worked so hard to build on these teeth. So that's the beauty of these. They will give you a high shine without removing that fine texture that you've developed using burrs and your enhanced points. And this is now the final restoration. You can see this is immediately after removal of the rubber dam. Obviously, the shade is not going to be as perfect because her teeth, her natural teeth, are dehydrated, because of my rubber dam. But that's why I always take a photo, and you can see this is a 90-day follow-up. So this is now 3 months later. The tooth is still working well. This tooth is still in the patient's mouth. And you can see that the color has now blended in a lot better. And again, the tooth is not, you don't see any gray around it because we had that white layer underneath this universal shade of composite, which gives it this very, very nice opacity. But I always get the question, how long do these restorations last? And I've shown you one 3 years post-op, but that was more like a Maryland type of bridge. In these type of roots, I'm sharing with you here another case. And again, using the same system, the same composite, every single step the same way. You can see where we started on the left-hand side, 45 days after I completed a restoration. This is a different case, and this is now 20 months later, almost 2 years, and we're still holding on to this tooth. This patient still has this tooth in her mouth, and the root is still there. You can see that there is no inflammation of the tissue. There's no periapical lesion. There never was. The root canal was there for 25 plus years, so it was a really old root canal. We knew that it was behaving well. Why not give it a try? And we always give it a try because these procedures, they work very well. And again, my end goal is not to have these teeth for the rest of the patient's life. I never say that to my patients, but I do tell them this is a long-term temporary restoration. When you are ready, we will be ready to go forward with any final treatment that you may accomplish. Now, many of my patients will then say 20 months later, hey doctor, is there any way that I can keep this restoration until it literally fails and then we go and move forward? And I always say yes, because the root is there. It's keeping the natural contours of the gingiva, it's keeping obviously the bone, it's keeping everything that I need to maintain is there with my restoration in place. So again, keep that in mind, keep this option in mind, and give it a try. If you haven't used this technique, give it a try following our advice and following our recommendations. We've made a lot of mistakes when we're learning how to accomplish these restorations. But what we're giving you today is a solid information with solid foundations. So I hope that you have enjoyed this webinar.